Progestogens are needed within HRT to protect the endometrium, the lining of the uterus, from the effect of estrogen. We know from many studies that taking estrogen on its own for longer periods of time can result in abnormal thickening of the lining of the uterus, as described as hyperplasia, and even that can turn into cancer if taken for long periods of time. So it's important that progestogens are given within HRT to protect the endometrium from that effect. So there are two different ways of giving progestogens within HRT, and that largely depends on where the individual woman is in her background entering into this process. So if a woman is perimenopausal and is still having menstrual cycles, HRT is given in a sequential preparation. And within that, the individual will experience a bleed every month. But if the individual woman is into the menopause and her periods have stopped more than 12 months, HRT is given in a way where progesterone is given all the time and there is no bleeding within it. So within sequential HRT intake, estrogen is given throughout the cycle, and then progestogen is given for 12 to 14 days within that cycle. And after completing that 12 to 14 days, there's usually a withdrawal bleed at the end of it. With a continuous combined intake in an individual who's gone through the menopause, estrogen is given throughout the cycle and progestogen is also given throughout the cycle, and that is intended not to be associated with a bleed. So progestogens are different. So there's micronized progesterone, which is similar in chemical structure to the progesterone produced by the human ovary. And there are a number of synthetic variants that are available within HRT preparations. In general, they all serve the same concept. They are opposing estrogen, they are protecting the endometrium. And from that point of view, they all work really well. But there are small differences between them. So if you look at micronized progesterone, for example, or certain types of synthetic progesterones like dydrogesterone, they bind very selectively to the cells in the lining of the uterus. So often are described to have less side effects than other synthetic progestogens. And some of the synthetic progestogens may have androgenic properties and they may have side effects from that point of view. But also, over the years, we've also had studies that looking at the safety profile with these progestogens, and studies do suggest that there is some element, albeit marginal, between these different progestogens. So studies have looked at the effect of blood clots, venous thrombosis, and have suggested that certain types of progesterone, particularly micronized progesterone, dydrogesterone, may be associated with a lower risk of blood clots compared to other synthetic progestogens, albeit these differences are small. Even with breast cancer, there is a suggestion that micronized progesterone and dydrogesterone may be associated with less of an increase than other synthetic progestogens. But the point that one would stress that these differences are small, and this shouldn't be a reason to say that you can or can't take this or should not take this preparation, because these differences are very small in that respect. So progestogens can be given vaginally in situations where there are side effects with oral intake. So if we talk about micronized progesterone in particular, the way of giving it is to give it as an oral capsule. But if an individual experiences side effects with it, and that's related to the breakdown of the product of the capsule, that the progesterone can be given vaginally, and that will be either by giving the same capsule vaginally or using pessaries that are manufactured for use in fertility that can be used in this context out with the manufacturer's license. We have got the information that we've got on progesterone in particular is with oral intake. So when we give it vaginally, we would say to the individual patients that this is likely to be safe. We've got the safety data from a different context, from a fertility aspect, and we know that they get absorbed well, but we have got limited information in relation to the effect with vaginal absorption, to what is the optimal regimen. So there are some limitations. So we often don't use it as a first line. So it'll be used in a situation where people are experiencing side effects with oral intake. And in this situation, when we use micronized progesterone in this context, we do counsel the patient that we would say to them that we would advise them to take it in the same doses and the same durations that they would do with taking it orally. Now, of course, this is in relation to micronized progesterone. If we look at other progestogens, the synthetic progestogens, often they are given in oral preparations, but we also have some synthetic progestogens given in patch preparation. So we've got the Everel patches, the Everel Conti and the Everel Sequi are given in a patch. They give novatesterone, which is absorbed well through the skin and is effective in that context. We've got the FEM7 patches. Again, we've got the FEM7 Conti, the FEM7 Sequi, which although it's now out of the market, should be back, expected to be back in 2024. These have got levonorgestrel in them. And again, they are effective, absorb well through the skin. So that's another delivery method. And even though these are synthetic, we've got data that show that neutral from a blood clotting perspective as well, given through the skin. We've also got the intrauterine devices that give levonorgestrel. So the Mirena intrauterine device or some other devices that have 52 milligrams, similar dose to the Mirena, can be used in this context to deliver progestogen through the uterus to provide an effective protection of the endometrium. So progestogen-only pills contain different types of progestogens, and novatesterone, for example, is being used in many HRT preparations. So, and of course, on the other hand, if you ask the question of if we want to give novatesterone with an HRT, do we have preparations to give it on its own? And the answer to that part is to say that many of the novatesterone-only preparations contain a high dose of novatesterone, probably higher than what you need with an HRT. So, as an alternative in clinical practice, sometimes you can use a progestogen-only contraceptive pill and give an equivalent dose to what is needed with an HRT. So for example, if you take a novatesterone-containing progestogen-only pill, such as Noriday, each pill has 350 micrograms. So if you take 3 of these a day, that'll be just over 1 milligram. To be more specific, 1.05 milligrams. And that will provide sufficient protection for the endometrium. So that can be combined with a gel preparation or a patch or a spray to give the progestogen intake that is needed. And this could be done in a sequential intake or a continuous intake, often in a continuous intake, because then you could say it's offering contraception as well if the individual needs contraception. A different type of pill, desogestrel, is now very commonly used for contraceptive purposes, and it's often associated with a higher chance of not experiencing bleeding. Desogestrel in the dose used for contraception, the 75 microgram. If you ask the question, can we use that as the progestogen component of HRT? The answer is we haven't got the information on it. It may well be sufficient, but we haven't got the studies to show it. We do have, however, older studies that have looked at desogestrel in double that dose, 150 micrograms, used with an HRT, and that has been shown to be effective. Also, desogestrel in a 150 microgram dose is currently used in the UK in 2 combined hormonal contraceptive pills with a much higher dose of synthetic estrogen. So we've got good safety data, so that will be another option. So you could say an individual may choose to take 2 tablets of desogestrel with estrogen, and that will give contraception as well and sufficient protection of the endometrium. However, in practice, when desogestrel 75 micrograms is used, if HRT is added more often, people can give progesterone with desogestrel 75. So someone may be on desogestrel 75. This gives sufficient contraception, but it's not enough for the progestogen part of HRT. So that can then combine, for example, with utrogestan, given continuously or sequentially, to provide the progestogen component of HRT, and it will provide contraception. And of course, if we want to move in a parallel way, you could say the Mirena intrauterine device or any 52 milligram device will offer contraception, and that can be used on its own as the source of progestogen protection of the endometrium. So the Mirena, for example, is licensed for 4 years, but we've got good clinical evidence to say that it works for 5 years. So that can be used for 5 years as a contraceptive and as the progestogen component of HRT. So in principle, we follow that logic. And you can say, if you look at HRT preparations that are manufactured in a combined fashion that have different doses of estrogen, that concept is already applied. So if you take an HRT preparation that has, let's say, an average dose of estrogen, it may have a certain dose of progestogen that opposes it. some of these preparations, if they have a higher dose of estrogen, you will note that the dose of progestogen within these preparations goes up to match the dose of the estrogen. And that follows that logic. But of course, when you're taking it as one tablet, you wouldn't notice it. And you think you've gone from this dose to the next dose. What's happening in clinical practice now, it's common practice for people to use estrogens through the skin and combine them with micronized progesterone. So there is a bit of a mix and match, so to speak, in adding this. So really, and of course, within that also, there is an adjustment with the doses. So someone might start on a standard dose of a patch or gel. They don't get sufficient symptom control, they up the dose gets increased. And within that concept, we always have to keep in mind, what are we doing with the progesterone? What are we doing with the progestogen? And we need to keep that concept in mind. And of course, it's a difficult balance, because then comes the question of saying, what is high? And if you're giving X dose of the patch or Y dose of the patch, when you go up, with what increase would you need to increase the progestogen? And of course, here comes another variable, which is the variation in absorption with the estrogen with the different preparations. So we would often say in practice, if you're using a combination where you're giving the estrogen in one way and the progestogen in a different way, keep in mind that the dose of the progestogen needs to be relative, proportionate to the dose of the estrogen. And often we would say, if you go to a high dose of estrogen, let's say, for example, 100 patch or 4 measures of gel or so on, keep in mind that the dose of progesterone will need to be increased. For example, if you're giving Progestogen, think of increasing the dose. If you're giving it continuously as 100 milligrams a day, maybe go up to 200 milligrams a day. If you're giving it in a sequential preparation, 200 milligrams for 12 days a month, maybe go up to 300 milligrams to keep it in line, in proportion to the dose of estrogen given.